We're here with Dr. Garcia today. We just finished an L5-S1 spondylolisthesis case where we did a decompression and an interbody fusion and percutaneous screw fixation, all minimally invasively. And we've been talking about other cases, and we're now about to discuss a longer 9-level case in which we apply the same principles we do to the shorter constructs, but take it steps further so we can treat some bigger deformity. This lateral X-ray is of a patient who has classic symptoms of lumbar spinal stenosis. You can see he has a multi-level disc collapse and has lost his lordosis. In fact, he's really kyphotic from L1 to L3. There's a slight maybe retrolisthesis here, and he had multi-level spinal stenosis. So we can take a look at his AP view, and you can see these large lateral osteophytes on the patient's right-hand side, and also up here. There's a small concave curve to the right with its apex here at L2, L3. He's had a previous hip replacement. Overall has good bone density, and so this patient went through a combined anterior-posterior procedure with placement of interbody spacers at L1, L2, 2, 3, 3, 4, 4, 5, all through a lateral approach. And then in stage 2, we performed a transforaminal interbody fusion at L5-S1, completed the decompression with a minimally invasive approach through decompression tubes, passed our screws, and then passed the rods in a percutaneous manner. Take a look at the AP view here, and you can see the screws as well as the rods in good position, the interbody spacers in good position, and he's regained his some of his height and some of his contour to his spine, and should go on to heal quite well.
The scoliosis was corrected, right?
Pardon me?
The scoliosis was corrected.
Yes, but he had a little minimal curve, and that was correct. And we get most of our correction really from placing these large lateral spacers. They afford us the opportunity to reintroduce lordosis with lordotic, but the final correction really can come from bending the rod to the position that we want, passing it through the tulips, and by tightening down the screw caps in the tulips, it pulls the spine into a nicer lordosis.
And so then it's just a matter of using your eye to determine which kind of bend you want, where you want, the appropriate lordosis, how much kyphosis to bring over the top. And of course that's dictated by the patient, what's normal for that patient and the patient's spine. And so by comparing your pre-op x-rays with how you want it to look, bend it to that curve, and then you pass it percutaneously. And as we saw with these screws, the threads go up about 3 centimeters. So as long as you're under the muscle, under the fascia, the screw caps help seat it in. So it's not as difficult really as you might think it is. It truly is not.
But normally you have to do bend of the rod.
Right? Yeah.
Okay.
Yeah. I would tell you honestly, I think in most of the 1, 2, and 3 level cases, we don't do much rod bending because we use pre-contoured lordotic rods, and they're a very average lordosis. Sometimes we take a little of that lordosis out for people, sometimes we put a little bit more in. But it's just a matter of, typically what you would do if you're doing, T10 to the sacrum open, you're bending that rod. And so you do the same thing as you used to do open, but you're just sliding it percutaneously.
Do you think it was not necessary to do a fixation up there?
Yeah, it's definitely not the wrong answer as far as this goes, and it's interesting because I think the standard, most accepted answer is yes, you should go T10 to the sacrum. But for me, and when I have patients who have multiple medical problems, we balance longer procedures and more extensive surgeries with, and also balance it with their activity level. For people who just can't get out of the house and they want to be able to get out and go to dinner and go to church versus people who want to be on the golf course, we sort of modify our approach. And then I think lastly, although people will, at meetings will say, oh, you always need to go to T10, when you talk to them on the side, they say, well, there was no kyphotic deformity at T12, L1, it was relatively straight. I thought I could get away with it. And so maybe it's not good to get away with things, but sometimes in elderly people, maybe you can save them some morbidity if you do less instead of more. But that's an excellent point and certainly not a wrong answer to go to T10.
What is the most famous complication about this kind of surgery?
Yeah. The most difficult thing, in my experience in working with surgeons, is to really just to get them to go to training and apply it and take that step of doing that first case. That's the most complicated part. Sure, you'll run into the occasional dural tear, but it's a dural tear. We're all used to fixing those. Is it a little more difficult to sew it in a tube? Sure, it's a little more difficult, but it doesn't happen often, and it's part of the risk. But I don't think there are any specific things that are any different than open. You know.
We've been here with Dr. Garcia. We've performed a minimally invasive surgery case. We've had ample opportunity to discuss options and plans for the future to educate more surgeons on minimally invasive surgery, and I'd like to thank him so much for his presence here today.
Thank you.